Hello, everyone. Let me first thank the organizer for their very kind invitation to speak today about Candida auris, a new yeast threat. This is my disclosure slide for this presentation. Candida auris is an emerging fungal pathogen, and the media has been quite hot about it, as you can see here on the New York Times or the BBC. At the bottom part, you see that the New York Times said Candida auris, the fungus nobody wants to talk about, but we are going to talk about, and I'm going to tell you what you need to know about Candida auris. When did it emerge? The first isolate probably was cultivated in 1996 in South Korea, but the first report or first discovery was in 2009. It came from the external ear canal of a patient in Tokyo, Japan, hence its name. And now it's present in more than 30 countries on 6 continents. On the left-hand side, you have the dissemination throughout the world. There are now 4 clades, a South and East Asian clades, a South African one, and a South American one. And what is interesting is the fact that there is a high diversity between the clade and an extreme clonality within clade, and it probably has emerged at the same time at various places. How does it look like on plates? And here on the left-hand side, you have Candida auris on chrome agar in the laboratory of microbiology. It's white to pink to red and sometimes purple colonies, as you can see. It's a budding yeast. It almost never forms short pseudohyphae and does not form germ tubes. Interestingly, it grows very well at high temperature in the range of 40 to 42, which is different from other Candida species. At the bottom part here, you have an algorithm for identification of Candida auris from the US CDC. What can you do to identify Candida auris in the clinical micro lab? 2 things that you can do, use the MALDI-TOF, it's a reliable technique, or using sequencing, which also identify nicely Candida auris. But if you use other methods like the 3 mentioned at the bottom part of the slide, it's not reliable because you may have misidentification as Candida hemolunii, Candida flammata, or lusitania. And why is that? And this is shown on this slide, that it's closely related to the other Candida species, in particularly Candida hemolunii. And please note, and we're going to address that later, that it's also a resistant clade in terms of Candida species. In Europe, here is the data. On the left-hand side, you have the first update from 2 years ago from the European CDC, about 620 cases that were collected between 2013 and 2017. As you can see on the map, most cases were sporadic cases. However, there were outbreaks described either in the UK or in Spain. On the right-hand side, you have the most recent data from 2020 from the CDC, European CDC again, about 349 cases. As you can see, about 3/4 of cases are just colonizing organism, about 1/4 are bloodstream infection, and there are just few other infections. And as you can see at the bottom part, most of almost exclusively the cases have been documented in Spain and the UK, but now we have a report from isolate in Greece, in the Netherlands, as well as in Poland. Here are 2 examples. an outbreak at the Royal Brompton Hospital in London, 50 cases of colonization, 22 patients infected, 9 candidemia and 13 non-candidemia. And this was an outbreak, an increase and a decrease. And there was no attributed deaths to the Candida auris. In the right-hand side of the slide, Hospital La Fe in Valencia reported 100 cases of colonization, 41 cases of candidemia. There's a very high rate of mortality, 41%. There has been a report also from the US, here published in Lancet Infectious Disease 2 years ago, about 73 clinical cases and 60 screening, in total 133 cases. As you can see, there were multiple introductions from various areas in the world, the African clade, the South Asian clade, and also the South American clade. And at that time, there was ongoing transmission within states, but not between states. So there is transmission locally in healthcare network. In Switzerland, we also had one case, which was our first Candida auris case. This was a patient who developed severe sepsis from CAP and ARDS requiring mechanical ventilation in northeast Spain. The patient was transferred to Geneva on the 18th, and the Candida auris, was isolated from tracheal aspirates in Spain, and then the patient was colonized at multiple sites in Switzerland. As you can see, there was a high degree of resistance to fluconazole, resistant to voriconazole, but sensitive to caspofungin. We'll come back to that later on. And the patient died of septic shock, but due to bacterial sepsis and not fungal sepsis. We had no cases from our network of fungal infections in Switzerland so far. Candida auris is an agent of nosocomial infection. It contaminates surfaces. It contaminates also shared instrument. Be particularly aware of probes for measuring axillary temperature. It persists on skin and tend to colonize skin rather than the GI tract. It can form biofilm, less than Candida albicans, and it has the ability to survive on dry or moist surfaces, again, less than paropsilosis. What about antifungal resistance pattern? Here you have 4 studies from North America, from India, England, and Spain. You see across the board that the resistance rate to fluconazole and voriconazole is quite high. Resistance rate to amphotericin B varies. It's 35% in the US article, and it was 3% in India. It's sensitive to the echinocandin, although we have now reports of increasing resistance. And as you can see here, Candida auris was resistant to 2 or more antifungal classes in a high proportion of patients. And there are various reasons for these mechanisms of resistance, and I'm not going to go into that. The good news is that we have new antifungal agents like risafungin, with low MIC, ibraxafungerp, also low MIC, around 1 microgram per ml, and 2 other drugs as well with low MICs. So in conclusion, what can we say? Candida auris has recently emerged as a new yeast species. It's present in all continents, has been reported from more than 30 countries. there is a rapid emergence from a limited number of foci, and we don't know exactly why this has happened almost simultaneously in various parts of the world. As I mentioned, you can isolate it with MALDI-TOF and its reliable technique or sequencing. If you use other techniques, be aware of misidentification. It causes nosocomial infection. It persists on surfaces. It colonizes the skin rather than the GI tract. It's resistant to antifungal agents, primarily fluconazole and the other azole, but also sometimes to amphotericin B or hospital disinfectant, and it's susceptible to echinocandin, but resistant has been reported, and there are new active antifungal agents. The degree of virulence varies quite a lot. Has been reported to be associated with death rate in the range of 30, but up to 70%. But the jury is still out on that, and prevention is essential. I thank you very much for your attention.